This conference will now be recorded.
Okay, so today we are going to discuss this 2017 October talk, that is management of pregnancy after trachelectomy for early cervical cancer. This is an important talk. Why? Because this is the trachelectomy is the surgery which is usually done for the early cancer cervix, which where the patient wants to preserve her fertility. So this talk is about what are the problems after the trachelectomy in the patient who conceives. Okay, so just how to manage her antenatally and intrapartum. The talk is regarding that. So approximately 52% of cervical cancer they occurred under the age of 45 years. According to this is 2012 data. And now in recent guideline, actually this is not yet published, but what they are telling is the most increased incidence is observed in between age 25 to 29 years, early cancers. So with this increasing number in early age, fertility preservation becomes a priority and key factor in the quality of life of the patient. So what are these fertility sparing surgery for early cervical cancer? So for stage 1A1, it is cone biopsy without or with or without lymphadenectomy, depending upon the lymphovascular space invasion or other factors. And for 1A2 and 1B1, it is radical trachelectomy along with lymphadenectomy. So this trachelectomy can be done by either a open abdominal, vaginal, or laparoscopic route. So what do you mean by this trachelectomy? So it is the removal of cervix along with surrounding tissue, which means parametrium and upper vagina. So now remember well, trachelectomy is the removal of cervix with parametrium and vagina. Trachelectomy doesn't involve lymphadenectomy. So whenever you consider the surgery for cervical cancer, it is trachelectomy, radical trachelectomy along with lymphadenectomy, pelvic lymphadenectomy. But as per trachelectomy, trachelectomy means only removal of cervix and surrounding tissue, that means parametrium and upper vagina, in order to achieve oncological clearance of the central tumor while retaining the uterus. The uterine isthmus and vagina, they will be re-anastomosed and a permanent suture is placed in the ischemic part of uterus, okay, to avoid the preterm labor. So it is the os tightening, what we can call it is, and so it will create the neocervix. So here the basically the suture will be placed and it will be a permanent suture. So the oncological results, what they have found out is oncological results of radical trachelectomy is as compared to as that of radical hysterectomy. So and 5-year survival is very high. It's around 95 to 98% according to this cancer research data. Recurrence rate are similar by whatever route you do the trachelectomy. So either open laparoscopic or vaginal, whatever it is, the recurrence rate are similar. So route doesn't matter in which you are doing this trachelectomy. So this is the diagrammatic representation of this radical trachelectomy. So you can see this is the portion which is removed by this radical trachelectomy, and here the suture will be inserted. So whenever a patient has undergone radical trachelectomy, she should avoid pregnancy for at least 6 months after trachelectomy for the healing of that cervical and isthmic portion. And then before embarking on the pregnancy, basically this recurrence should be confirmed, so that there should be no recurrence. And how you are going to confirm that there is no recurrence is negative colposcopic assessment, vaginal vault, isthmic smear, and pelvic MRI. So to rule out any recurrence, you have to do this investigation before embarking on the pregnancy. And for this 6 months, a contraception is advised. Now, what is the ideal contraception in such cases? So basically, this is combined hormonal contraceptives, subdermal implants, and progesterone implants. So whatever you can call it as, and injections also for that matter, they are safe. Okay. So these are the safest option for this trachelectomy patients. Progesterone only pill, it is a eugemic one, but the mechanism of action of progesterone pill is thickening of cervical mucus. Here you have removed the cervix, so it may not be effective. So even if it is a category 1 pill, category 1, you can make category 1, still it may not work because it primarily acts by thickening of cervical mucus. So the best choice will be either pills, injections, or progesterone implants. Now, insertion of IUC, that is IUD or levonorgestrel IUS, they can be technically challenging because of this difficulty in locating the ischemic os and because of ischemic stenosis. So it should be attempted by an experienced clinician. If patient wants to have that mode of contraception, then it should be done by an experienced clinician. Now, up to 61% of women who conceived after this trachelectomy, they require assisted reproduction techniques to achieve a pregnancy. Because again, you can see the cervical mucus factor will not help in the transport of the sperm, so that there might be some difficulties in conceiving. Okay. Now, once the patient conceives, what are her problems or what are the complications that can arise? So because of this shortened cervix or this neocervix formation, it is leads to loss of mechanical, cellular, biochemical and immunological barriers. So which will cause cervical incompetence, or in the trachelectomy, you can ideally say it's ischemic incompetence, which will cause ascending infection, higher risk of second trimester miscarriage, premature labor, pre-prom and chorioamnionitis. So these are the things that you should try to prevent when the patient becomes pregnant. Again, detection of labor may become difficult to assess because there may be endless progressive dilatation of this neocervix, so which will lead to mid-trimester abortion or preterm labor, where the incidence is as high as 25 to 28%. So whenever a patient wants to conceive, she should be explained regarding this risk, and she should be managed as a high-risk pregnancy. So rate of first trimester miscarriage in a meta-analysis, what they have found out is rate of first trimester miscarriage is 16%. So which is comparable to that of general population. So at general population, the rate of first trimester miscarriage is around 15 to 20%. But the rate of second trimester miscarriage with trachelectomy is 7%, which is higher because in general population, it is around 4%. So second trimester miscarriage is almost doubled. Also, the most cause of the second trimester miscarriage is infection and pre-prom. So if the patient has this first trimester miscarriage, how you are going to manage with this patient? Because she will have a permanent suture. So basically, medical management will be preferred in case of first trimester miscarriage, because you don't have to remove the surplus tissue. Next thing is, if she requires surgical evacuation, in that case, you have to use Hager size 7 dilator. Up to size 7 Hager dilators you can use with this neocervical, through this neocervix, and you can do surgical evacuation. But it should be usually done under ultrasound guidance, and it should be done by senior clinician, because locating the os is also difficult and there is an increased risk of operation. Now, for second trimester miscarriage, when you want to manage the second trimester miscarriage, you may have to remove the cerclage before any prostaglandin regimen, or you have to go for hysterectomy, depend upon the gestational age. So these are the two options that are, so either you have to remove this at cerclage suture, or you can go for the hysterectomy depending upon the gestational age. Now, risk of preterm delivery post trachelectomy, it is quoted to vary between 20 to 30%. Current review, so this author, they found it's around 45%. And 55% of women, they deliver only in third trimester. So before that, either they will abort or they will deliver preterm. So 45% will deliver, they will either abort or they will deliver before third trimester. So how you are going to manage her pregnancy? So every woman, she should be considered as a high risk, and early referral to consultant-led unit with multidisciplinary input, multidisciplinary team. Am I audible? Can you hear me?
Yes, ma'am.
Ma'am,
Okay.
Yes, ma'am.
Yeah. Okay.
now it's
So,
okay.
yeah. Okay. So the pregnancy should be booked in consultant-led unit with multidisciplinary team management. This is the first thing, and it should be managed as high-risk pregnancy. Then progesterone pessary should be used from 12 weeks of gestation until 36 weeks. 200 milligram twice a day vaginal progesterone pessary should be used up to 36 weeks. Serial fortnightly ischemic lymph scan. And it should be done by an experienced person, because who is experienced in doing such scans. Urine should be tested for culture sensitivity and vaginal cultures for bacterial vaginosis, because these are the basically because ascending infections are common because these barriers are lost. So you have to take utmost precaution that she should not develop any urine infection or bacterial vaginosis. So you can consider prophylactic antibiotic also if it is clinically indicated at 16 and 24 weeks. So urine culture sensitivity and vaginal culture should be done at first visit, and then any infections are there that it should be treated. Prophylactic antibiotics can be considered at 16 and 24 weeks. Also after 24 weeks onwards, consider prophylactic steroids because she can go anytime in preterm labor. So it's better to give her course of steroids. Then avoid unnecessary digital vaginal examination. Again, to rule out avoid any infection, consider avoiding sexual intercourse from 20 weeks onwards because it can be a source of infection. Also, avoid strenuous activities like heavy lifting, exercise, prolonged periods of standing. Also, in this talk, they have given one more thing, that avoid swimming or bathing in tub. Okay, because this can be also additional source of infection. Second trimester onward, all this. Avoid elective dental work during pregnancy because again this periodontitis is a main source of this preterm birth. Commence antibiotics and prophylactic steroids if preprom is occurs, okay, and deliver, and you may have to deliver her earlier, so that if preprom occurs, commence antibiotics and steroids. And the mode of delivery will be elective cesarean section at 37 weeks, but maintain a low threshold for delivery in case of preterm pre-labor rupture of membranes because there is high risk of subclinical chorioamnionitis. So it's difficult to diagnose this chorioamnionitis. So you may have to deliver earlier before she develops a frank chorioamnionitis. Now the mode of delivery, as I told you, it should be a planned or pre-labor cesarean section at around 37 weeks because there is risk of uterine rupture and severe hemorrhage if contractions occur. Then while doing cesarean section, basically there will be either absent lower segment or poorly formed lower segment because of this severe distortion of this anatomy of is because you are amputating the cervix at around isthmus. So there will be distortion of anatomy. So there may not, the lower segment may not form totally or it may be poorly formed. So there is a risk of extension of this transverse lower segment uterine incision, which will cause catastrophic hemorrhage. So basically, previously, traditionally, it was recommended that classical cesarean section should be done. But now, what they advocate is if the lower segment is sufficiently well developed, you can take transverse incision also. But you have to consider that there might be technical difficulty while obtaining the adequate exposure, and also hemorrhage should be anticipated, and usually this surgery is performed in presence of senior clinician. Okay. So this is regarding this talk, this very short talk. Actually, this talk is very big, 7-8 pages. But what is this is what you have to require. There is one table. I have taken whole table in this. These two slides are there from that table. That is the table which is required for you. And another thing is those percentage and contraception. So these are the three important things from this talk which you should know. So coming to the questions of this talk. So this is the first question. Type your answers in the chat box. 33-year-old woman has been diagnosed with stage A12 carcinoma of cervix. She has been, 1A2. She has been offered fertility sparing surgery in form of trachelectomy. So what does this procedure entail? Yeah. So it is D, removal of cervix, upper vagina and parametrium. You should not write E at all because lymph node doesn't come with trachelectomy. So lymph node is lymphadenectomy is a different. So it is called as radical trachelectomy plus pelvic lymphadenectomy. It's a complete surgery for this 1A12, 1A2. Okay, but trachelectomy means only cervix, upper vagina and parametrium. Second thing, what is the treatment of choice in 32-year-old single woman with stage 1A1 cervical cancer and who has never been pregnant? Yeah. So for 1A1, It is a cone biopsy, knife cone biopsy, or it can be leads also. Okay, if the patient has already undergone leads and the margins are clear of dysplasia plus cervical cancer, then that treatment is also sufficient in case of 1A1. So it can be either leads or cone biopsy. So this is regarding this talk. Tomorrow we will meet with another talk. So thank you for attending. Bye all.
Thank you, ma'am.